Hi, I'm Dr. Robert Kaufmann, and we're about to go beyond the terminus. Today we're starting the first of what will be a series of case studies. Arnie was a 40-year-old male who was referred to me in October of 2018. The referring dentist was considering replacing the crown in this previously traumatized maxillary left central incisor. He had concerns about the endodontics that was performed in 2000. The patient was asymptomatic at the time of my initial examination in 2018. Periapical images did not show anything remarkable, although small voids were noted in the coronal aspect and below the post. I suggested that the referring dentist could proceed with restoration of the tooth as long as there was no other evidence of radiolucency or symptoms. The tooth was restored with a crown, and the patient was subsequently referred to me in 2020 when the referring dentist saw an unusual radiolucency in the midroot of his periapical image. This area was also associated with a draining buccal sinus. The patient's complaint at that time was slight palpation sensitivity over the buccal midroot of the tooth. CBCT imaging now showed a large area of resorption on the labial aspect of the root, but no evidence of unusual periapical findings at the apex. I decided to attempt to repair this area surgically. In December of 2020, I raised a flap and restored the resorbed area with Gerrestore. I polished the area as best as I could, and I was satisfied that the margins were reasonably tight and the composite was well finished. I didn't resect the apical portion of the root at the time of surgery because apically there was no evidence of radiolucent finding either in the periapical or in the scan. The problems seemed to be confined to the midroot. The soft tissue area healed well. Things seemed to be going well until March of 2023 when Arnie returned with a localized swelling over the labial root surface where I had performed the repair. Eventually, a draining sinus formed, and I was at a loss to explain why my surgery had failed. I discussed the case with another local endodontist, and we agreed that the post should be removed through the crown and the coronal aspect of the canal should be re-cleaned and repacked to ensure that we weren't getting coronal leakage into the area of the surgery. The post was removed through the crown, and the coronal canal area was conventionally retreated in April of 2023. In June of 2023, the patient then returned again with a similar situation and a draining buccal sinus. He also had chipped the distal incisal part of the crown. The sinus was again traced to the midroot. The patient had already undergone one surgery and one retreatment, and I was fortunate that he was a very compliant and a really good-natured fellow. In July of 2023, he agreed to do a second surgery, this time completely resecting the root down to the level of the resorption and placement of a retrograde MTA in the canal. Again, the soft tissues healed well. Things seem to be going in the right direction, and 2 years after this surgery was performed, the area has healed completely. The referring dentist's composite repair of the chip on the incisal edge seems to be holding up pretty well. 6 months and 1 year post-op surgical recall images show the area to be healed, and he is asymptomatic. I'm not sure why the initial surgical treatment failed, but I found the case to be extremely interesting. I've always wondered why our oral surgical colleagues can get away with simply resecting the roots of teeth in order to deal with pathology without any consideration of the canal or its contents. But here's an example of a case where just removing the suspect area seems to have solved the problem. More case studies and information to follow every week. Remember, when we do the right thing, we both get better. Patients and clinicians. Make sure you like and subscribe so you're alerted when new videos are posted. Thanks for watching, and I look forward to our next trip when we go beyond the terminus. See you then.